Hi friends, today I'm going to talk to you about hyponatremia, which often people working in the emergency department find quite complex. Let's look at it. It's a state of low sodium levels in the body. Now, how would a patient present to you? Either they have had a blood test and you find that they have low sodium levels, or in severe cases, they may be having altered mental status, being drowsy, confused, or having seizures. Now, symptoms are linked to the severity of how low the sodium levels are and acuteness, how rapidly those levels have fallen. Now, going ahead, as your standard approach for every patient in emergency is doing a primary survey, taking a sample history, including the allergies, current medications, past medical history, and last check last sodium if they is known, and make an assessment of their volume status. Are they looking dehydrated, or there is edematous or normal volume? Now let's understand the concept. Hyponatremia, we said, is a state of low sodium levels. Now this could be relative or absolute. Our body maintains the level of sodium in a happy range of 135 to 145 milliequivalents per liter. Now, absolute hyponatremia, when there is low sodium, either because there is low intake or increased loss. And relative, meaning that the amount of water is excess relative to the sodium, which could be due to increased intake or decreased loss. Understanding that balance is the key, hyponatremia is classified as mild, moderate, and severe, and the symptoms can appear based on the severity and rate of drop. Now, the next step is getting a blood gas and a urine sample and checking plasma osmolarity based on this formula: 2 into sodium, glucose plus urea, millimoles per liter. If less than 275, it is hypoosmolar. And then on the urine, you check urine osmolarity and urine sodium. Now, urine osmolarity low means dilute urine, and urine sodium low may be that because person is drinking lot of water, like in polydipsia. If urine is concentrated and the urine sodium is low, then it could be because of lot of gastrointestinal losses. And if the urine sodium is high, that means the kidneys are losing out sodium, or it could be in syndrome of inappropriate antidiuretic hormone. Now, coming to treatment, if they are seizing or acutely symptomatic, treat them promptly with hypertonic saline. Give 200 mils over 30 minutes by a central line or large peripheral cannula, and correct no more than 8 to 10 millimoles over 24 hours, and check every 2 to 4 hours. If the GCS is all right, then if they are dehydrated, treat them with normal saline and antiemetic if they are vomiting. And if they are edematous or normal volumic, then fluid restriction and adding salt and considering vasopressin antagonists like tolvaptan should